Welcome to ANA Investigates, a podcast covering the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. ANA Investigates is by ANA members for ANA members, and that's never been more true than it is today. In response to the ever-evolving coronavirus pandemic, ANA members have come together to bring you this special episode of ANA Investigates recorded this morning addressing the neurological impact of COVID-19. As the number of infections swells worldwide, more patients with the virus have been noted to have neurological symptoms, yet the precise relationship between COVID-19 and these symptoms remains unclear. We asked ANA member Dr. Danny Bega to discuss the neurology of COVID-19 with his colleague and neuroinfectious disease specialist, Dr. Igor Koralnik. Danny Bega is assistant professor of neurology at Northwestern University Feinberg School of Medicine and the program director for the neurology residency at Northwestern.
Hello, I'd like to welcome everyone to this special issue of the ANA Investigates COVID-19, the neurological impact of coronavirus. Today is April 6th, and I'd like to welcome Dr. Igor Koralnik, who is Section Chief of Neuroinfectious Disease and Global Neurology at Northwestern University Feinberg School of Medicine. Dr. Koralnik is an expert in neuroinfectious disease and will be discussing on the topic of coronavirus and COVID-19, its impact on neurology. Welcome, Dr. Koralnik.
Good morning, Danny. Thank you for inviting me in this podcast.
This is a really unique time for neurologists and physicians everywhere. This is a special issue where the ANA wanted to specifically talk to an expert who can speak to the impact of the coronavirus emergency in neurology. We're well aware that the recommendations and guidelines and our understanding of the virus and its impact are changing day to day. And with that in mind, also noting that each of us are speaking from our own individual home offices, I want to thank you for making yourself available from your home office.
You're welcome.
So just to begin with, we are starting to become aware that coronavirus has an impact that directly or indirectly involves neurological manifestation. Can you talk about some of the pathophysiological considerations that we as neurologists need to be aware of, whether direct or indirect, as a result of coronavirus?
So as you know, COVID-19 is caused by the novel coronavirus called SARS-CoV-2, and about 80% of infected people have no or minor symptoms, especially children and young adults. Those symptoms may include fever, cough, fatigue, headaches that are similar to that of the flu. But in about 20% of people, especially after the age of 60, and also those with comorbidities, the disease can be more severe with pneumonia, respiratory failure, requiring admission to the ICU. So we don't really understand yet what differentiates people with minor symptoms from those with severe disease, including in young people. It seems that it has to do with the initial immune response to the virus, which is dysregulated and unable to contain the spread of the virus initially in those patients who do poorly. Now, the receptor of the virus has been found to be the angiotensin-converting enzyme 2, or ACE2, which is present in alveolar lung cells, but also in other cells in the body, including brain cells. So there are already a number of neurological manifestations that have been identified associated with COVID-19. And what we know about the frequency of those manifestations comes mainly from one single report of 214 hospitalized patients in Wuhan, China. One of the early neurologic manifestations is anosmia, or loss of smell, which can often associate with ageusia, or loss of taste. And it seems to occur in up to 5% of patients. And I think it's important for us to realize that because these are people who otherwise may not have any other symptoms. And it suggests the direct spread of the virus from the nasopharynx to the olfactory bulb in the brain. It doesn't mean that those people will develop an encephalitis, since those here appear to be mostly transient, but I think it has immediate implication for the isolation of affected people and to prevent infection, let's say, for other contact in the household. The most frequent neurologic manifestations are dizziness and headache. So dizziness is present in 17% of the patient, headache in 13%. Of course, this is non-specific, frequent in all viral infections, and it's possible that this is just associated with a systemic disease, but we as neurologists need to consider the possibility that this is associated with the meningitis and also dysfunction of the vestibular system. For example, SARS-CoV-1, the first SARS coronavirus that had an outbreak in 2003, had been detected in the CSF of some of the patients. There is a neuromuscular complication in COVID-19, which is myalgia, muscle pain, occur in about 11% of those patients, and that may be associated with rhabdomyolysis, high CK level in the blood, that can in turn cause kidney dysfunction and participate to the multi-organ failure that this patient may develop. Another frequent manifestation are altered mental status, impairment of consciousness, found in 8% of the patient early in the course of the disease. And it's also more frequent in those who develop severe disease after that. So we don't know if it's just secondary to respiratory disease, ARDS and hypoxia, or if it's primary and maybe caused by encephalitis, for example. So what we know from other coronavirus, that they have been shown to cause encephalitis in the past. SARS-CoV-1 can cause infection of the brainstem in mice that are inoculated in the nasopharynx. So whether this happened also in COVID-19 is not known, but this could potentially worsen the respiratory failure in those patients. Finally, there's been a recent case report of acute hemorrhagic necrotizing encephalopathy in a patient presented with COVID-19 and altered mental status. And they were able to do a CAT scan and MRI that showed the hemorrhagic lesion in the thalami, medial temporal lobe, and surinsular areas in this patient. Cerebrovascular disease appeared to occur in 6% of patients, including hemorrhagic and ischemic strokes. We do not know if this is related to the fact that the ACE2 viral receptor is also present on the vascular endothelial cells, including those in the brain vessel. But what we know is that severe cases of COVID-19 have high D dimers in the blood, which indicates that they have a hypercoagulable syndrome. So if you put all this all together, 36% of COVID-19 have some neurologic manifestation. And if you only consider those with severe disease, then 45% have neurologic manifestation. So we can safely say that SARS-CoV-2 frequently affects the nervous system.
Thank you. Do you think that this has implications for how we investigate patients who come in with neurological complaints, with altered mental status, with headache, in terms of spinal fluid analysis? And do you have any recommendations about that?
Certainly. I mean, this should be in the differential diagnosis of those patients. At this point, the respiratory presentation and the ARDS hypoxia is at the forefront of their presentation. And it's not always possible to do a spinal tap on those patients, but hopefully we will be able to investigate appropriately patients who deserve it and be able also to do CAT scan and MRI in certain cases and learn more about those neurologic presentations affecting the central nervous system.
And do you think that as we start to see more cases of COVID-19 around the world, that these numbers, you said around 36%, will have some CNS manifestations? Do you think that those numbers are likely to hold, or do you think that do you expect that those may be underestimates?
I mean, the numbers that I give you come from one single report from China at the early days of the disease epidemic. As you know, the presentation in various countries, also the death rate in various countries has been different depending on the age of the population in those countries. For example, it's higher in Italy than in China. And obviously, older patients may be at more risk of developing neurological complication as well. And I think that in those who survived COVID-19, we may expect more sequelae from the virus that affect their nervous system.
I was speaking earlier with my residents about their concerns, and if you could speak to a few additional potential neurological consequences. Ones that they were asking about included potential post-viral sequelae, things like Guillain-Barré and transverse myelitis, as well as prothrombotic effects on vascular disease and cytokine storming. Can you touch on any of those potential complications?
Certainly. So I think there's only been one case of Guillain-Barré reported in patient with COVID-19 that I know of, and also one case of transient myelitis with COVID-19. Obviously, it's difficult to bring those patients to MRI, especially when they are intubated in the COVID-19 ICU. And so we may miss some of those patients clinically. Maybe we'll learn more if we're able to do postmortem analysis on those patients. Obviously, there's a hypercoagulable state with high D-dimer in the circulation of those patients. So there is those patients at higher risk of ischemic stroke, and we've already seen those. And we will obviously learn as we get to see those patients also coming back in our clinic after the pandemic is over.
Can you talk at all about any long-term sequelae we should anticipate? Any long-term neurological consequences that you're aware of or that have been published?
So far, the epidemic is so new that there's no literature about that. But when we think that patients will have maybe encephalitis, they will have cerebrovascular disease, they will have neuromuscular disease. So those may end up being chronic complications of the virus, and we'll discover that when we see them, after the pandemic is over in our clinic.
Dr. Koralnik, can you please talk about how COVID-19 may impact patients with existing neurological conditions that we commonly see, patients with demyelinating diseases, other neuromuscular diseases, potentially even neurodegenerative diseases, what the implications are for those patients?
Danny, this is an excellent question. First, we need to be aware that the pandemic is causing a lot of distress and anxiety to everyone. So this could magnify any symptoms associated with any neurologic condition, patients who are not infected by the virus, including pain syndromes, for example. Now, COVID-19 will alter the presentation of patients with some neurologic disease already causing difficulty breathing, like ALS, certain patients with myasthenia, patients with variety of spinal cord disease. So these may be at risk of severe lung infection, especially older people. I think we need to be aware also that some of the experimental medications that are now being tested in COVID-19 patients may have neurological side effects, especially chloroquine or hydroxychloroquine that may unmask or worsen myasthenia, for example. Neurologists also have to consider long-time treatment of their patient on immunosuppressive therapies, including those who require infusion in the hospital. There is discussion in the MS field, for example, to delay B-cell depleting therapy if possible in their patient. I think it's still very important that patients keep taking their medication to prevent the worsening of their neurologic disease. Now, on a lighter note, it seems that the pandemic seems to have also triggered a new neurologic entity, which is protective personal equipment associated headache. There has been a series of 158 healthcare workers in China that were using face masks all the time, and 80% of those developed de novo PPE associated headache. So I can somewhat relate to that since I just finished a rotation as a neurology consultant attending the hospital where I had to wear a face mask all the time as well. It seems that 30% of those people had a baseline primary headache, and 90% of those said that the increased use of the PPE had affected the control of their baseline headache as well. So we can only hope that this will subside when the pandemic is over and we do not need to wear a face mask all day.
I'm going to move on to ask you, looking forward as members of the ANA, as clinical and scientific members listen to this, what do you hope that they will do moving forward to advance our understanding of the COVID-19 infection? What should the focus of academic neurologists be in understanding the impact of it on the nervous system?
So I think nobody needs convincing that we're all in this together, and everybody is affected by the pandemic at so many different levels. So I think this is a time for action. There is obviously tremendous talent and expertise in various fields among academic neurologists, member of the ANA. We need all hands on deck now to fight this disease. I can only encourage my colleagues to put their expertise into the mix and join the research field either directly or in collaboration. There's always a consideration about funding, but there may be funding opportunities through their institution like we have at Northwestern or through NIH supplements on existing grants, for example.
Are there any specific research questions that you think should be highlighted?
Well, one of the main questions is what differentiates people who do well with the COVID-19, for example, children who are seldom severely affected, and those people who do poorly. What are the components of the immune system that are able to contain the disease initially, and those that are dysregulated and lead to the so-called cytokine storm that is associated with the pneumonitis and ARDS. And all the people who are working in the neuroimmunology field would certainly contribute to solve those questions.
Can you tell us a little bit about how you think this is shaping or will shape the field of neurology, and perhaps even telling us how this has affected your day-to-day practice and how you see this shaping or changing the field?
So obviously these are crazy times, very difficult times for everyone, professionally, also personally. Social distancing is taking a toll on all our interpersonal relationships. We are stuck at home, and when we are at proximity with colleagues in the hospital, everyone has to wear a mask, so you can't even see their facial expression anymore. I think it's very important to first try to restore as much normalcy as possible in our professional lives. For example, to embrace technology and really flip the narrative on the pandemic and transform social distancing into what I like to call distancing socially. That means to use all the web capabilities that we have to resume all the conferences like grand rounds, research seminar, faculty, lab meetings. And I think the same is true for all the teaching rounds with the fellows, the residents, and students. At the clinical level, everybody's already seen that all these new web platforms have transformed how we care for patients in the outpatient setting. That's accelerated the use of teleneurology, of course, by obligation. And it may be appropriate to continue using teleneurology for some of our patients after the pandemic is over, especially for follow-ups. I think on the research standpoint, we can use the extra time that we have now to start maybe new collaborations, reach out to people from different fields, engage more in team science. I think it's important, especially for young people who are starting an academic career. Now, everyone understands the importance of global health, and what happens on the other side of the planet can also affect them. And I hope that more academic neurologists will join the field of global neurology, which is not very crowded now. It's a very collegial and welcoming space. I think young people can develop their academic career there and immediately make a difference.
I want to thank you for participating in this call, and I wish you also that you stay safe and healthy, and to all of the listeners. Thank you.
Thank you. If I may, I would just like to send my personal greetings to all my friends and colleagues. Stay safe, stay strong, and we will all get through this together.
That was Dr. Igor Koralnik, Section Chief of Neuroinfectious Disease and Global Neurology at Northwestern University Feinberg School of Medicine, who was interviewed by Dr. Danny Bega, Assistant Professor of Neurology at Northwestern University Feinberg School of Medicine. This has been a special issue of ANA Investigates on COVID-19. Thanks to our listeners for tuning in. We're hoping you too can stay healthy and safe. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us. To learn more about today's program and to access more of the incredible content produced by the ANA, check out myana.org. Adeline Goss is our host. Our producers are Romer Giucaden, Adeline Goss, Michael Halstead, Megan Ritchie, and Jim Sigler. Our editor is Jen Hurley. If you'd like to learn more about receiving CME credit for listening to ANA Investigates, visit myana.org and navigate to ANA Investigates under the Education tab. For more information not covered in today's program, check out the official summary of this episode, published in one of the ANA's journals, the Annals of Neurology or the Annals of Clinical and Translational Neurology. Copyright, the American Neurological Association.